Yesterday, the FDA approved Suzetrigine, brand name Journavx, to treat moderate to severe acute pain in adults. This is touted to be a great new tool in the fight against opiate addiction, as it is a non-opioid painkiller that was shown in 2 trials to outperform placebo and to be similar to a low dose of hydrocodone in terms of pain control. In this video, we're going to go over how the medicine works, some of the background into the trials behind it, and what this could mean for the future of pain control. So, Suzetrigine is a medication that blocks sodium channels. More specifically, is a type of voltage-gated sodium channel blocker that is specific to peripheral nerves that sense pain. Now, you may be saying, what the heck are you talking about, and how does all this work? Well, so first we need to talk about how we feel pain on the cellular level. When stimuli like pressure, temperature, or the existence of certain chemicals exist in our body, this is sensed by nerve endings in the area of that stimulus. At a certain level, these stimuli can trigger that nerve to send a signal down a long line of the nerve called an axon, which kind of acts like how a telegraph or internet cable sends data across a distance. It then transmits that signal down to other nerves called peripheral nerves in the peripheral nervous system. It then reaches the spinal cord and then the brain, which is the central nervous system, and it interprets those signals as pain. How does that signal actually move down the axon? Well, kind of like how internet and telegraph cables send signals, but not exactly. They usually send pulses of electricity or light, and that light pulse and electrical pulse represents the data that's being sent. Nerves don't do data or electricity directly. Instead, they kind of change through a wave of an electrical gradient that changes. What nerves do in the axon is they are pumping electrolytes like sodium, potassium, and calcium into and out of the cell. So for example, with sodium, the nerves are using energy to pump the sodium out of the cell, making a higher concentration of sodium outside relative to inside. This makes both a chemical and electrical gradient as the sodium ions are positively charged. This electrical difference between the inside and the outside is something that can be sensed by voltage-gated sodium channels. Those run down the length of the axon, and if there's a drop in this potential, those channels sense the voltage change. They react to this by opening up and then allowing the sodium to flow into the cell. Think of this as kind of like how dominoes work. One channel opens, that causes a voltage change. That voltage change is sensed by the channels next to it, which then open, causing their own voltage change, and so on and so forth down the line until it gets to the end of the nerve. The nerve then resets these channels and the gradient, and then is ready to send another signal. The way Suzetrigine works is by blocking those sodium channels in peripheral pain nerves so they cannot send the signal nearly as easily. And if the nerves can't send the signal or need more stimuli to send the same signal, that means that the brain is going to think that we're having less pain because fewer and less intense signals are actually reaching it from the peripheral nervous system. This is how it's supposed to work in theory, but how well does it actually work in practice? Well, I quickly reviewed the paper that went over the results of 2 trials used to see how well Suzetrigine worked for acute pain. The trials were in post-operative patients who had either a bunion removal surgery or a tummy tuck, and they compared that pain rating of 48 hours of getting high, middle dose Suzetrigine against either a low dose of hydrocodone or a placebo. The patients were split evenly into 4 groups and weren't allowed to know what they were getting for pain, but were allowed ibuprofen as a backup for pain if they needed it. The study concluded that the highest dose of Suzetrigine decreased pain relative to placebo, but not lower doses, and they did not draw any conclusions about how well it worked relative to the current standards of care in terms of medicines for pain management. So what are some of the possible limitations to this study? First off, I want to say these are my opinions. I just did a quick review of the summaries of the trials and their results. I didn't compare the full text of both trials, so I might miss some things, or I might say some things that were actually addressed. But first, the studies were funded by Vertex Pharmaceuticals, who are developing the drug. They did try to control for this bias, as clearly they have a lot to gain from the drugs being successful, so they hired a team of third parties to run and interpret the trials to try to remove that bias. That should help, but personally I prefer studies that are completely removed from someone with a financial interest, but honestly those are rare because who would pay for them? Second, failed studies generally don't get published, so we have to hope that this does represent what the drug can actually do and just isn't the few studies that did support the medication working. Also, I usually like seeing raw data and interpreting the raw data myself rather than analyzed data, since you can do a lot of things with statistics to try to make the data look different depending on how you analyze it. Another thing that I couldn't find was if they controlled for the amount of ibuprofen used in each group, as that would be nice to know that the pain improvement wasn't due to the experimental group getting ibuprofen more aggressively than the placebo group was. This shouldn't be a problem if the study was properly double-blind, but it is still nice to verify that there was no difference that could be definitely skewing the results if the rates weren't similar between the groups. You wouldn't want to accidentally give one of the groups a nurse who is either way more aggressive or way less aggressive with giving ibuprofen, as that could introduce a factor that influences the results unrelated to how well the medication works themselves. Also, as far as I read, I did not see them control for prior chronic opiate use or for chronic pain, as those could also influence the patient's responses to the medications. Now, with all that being said, what are my personal thoughts on the medication? Well, from the trials, it seems like at a high dose, it could work similarly for acute pain control to a low-dose hydrocodone, but the trials were clear. They were not trying to establish any kind of relative effectiveness between the different pain medications. I definitely would like to see more data come out to try to make sure that these results are reproducible, and I would like to see some more data on the safety and efficacy, especially in comparison with other pain medications. Could there be a role for this medication for acute pain control and possibly even chronic pain control? I would say yes, as the mechanism of action and preliminary results seem to point to a possibility of it being useful, and as a physician who manages patients with pain, I'm definitely all for having more non-opiate pain medications, especially ones without any kind of abuse or addiction potential. But we're going to have to continue to watch and see what future studies show. Personally, I'm going to wait a little bit before I start to prescribe this medicine, as I'd feel more comfortable if there was more safety and efficacy data that would support it. I also read in one article that they were tentatively pricing it at $15.50 per pill, which in my opinion, and based on the trials, would severely limit its use due to cost effectiveness. Relative to how well it works in terms of outpatient use, I probably would really never recommend it at that price point unless it was covered by insurance or if cost just wasn't a factor.